Hello, I'm Dr. Nagat, an NHS GP with a specialism in women's health.
I'm Doctor Sooj, I'm an NHS GP and emergency doctor.
We're making an impromptu video, really because we have both attended the Women's Health Summit today, where the Health Secretary Victoria Atkins and also MP Maria Crawford, who is running the Women's Health Strategy, attended with the Women's Health Ambassador for England, Dame Leslie Regan. I was there in the capacity of my role as an ambassador for wellbeing of women, and also leading the Health Collective, which is hopefully going to be tackling some of the health inequalities and the disparities that we see in regards to delivery of women's healthcare currently. And Sooj, you were there today because?
I was there today. Sorry.
We'll edit that out.
No, that's fine. I was there today because I'm a clinician and because I do a lot of women's health content on social media.
So 5 points out of the meeting that came about today, which was really, really interesting, are essentially some of the strategies and some of the points that were already made in the Women's Health Strategy. Number one was looking at contraceptive care and making access to contraception easier by some of the implementation that's already happened. For example, contraception is available from your high street pharmacist and you don't need to see a GP, but you might still need a prescription from your NHS GP. Number two is maternity care and the disparities that we see from care around abortion and also miscarriages or missed miscarriages, and also trauma around birth as well, which Victoria Atkinson did also share her own birth story as well, which was really interesting. Number three is also looking at menstrual health, so problems that impact women greatly in regard to doing their work in the workspace. So from endometriosis, adenomyosis, PCOS, which was discussed in a lot of context today as well as fibroids, which we all agree needs far more funding than it does do at the moment. They also discussed about tackling inequalities in healthcare as well and research when it comes to marginalised communities, and finally menopause and postmenopause and beyond. And amongst that was looking at cancers as well. So that's cervical, breast cancer, womb cancer, breast cancer, which Victoria Atkins discussed that lobular breast cancer needs far more funding for. Mm-hmm. Was there anything that today stuck out for you?
Yeah, there was. So from speaking with all of the wonderful people that were there today, it's very clear that we need to educate young boys, young girls, much better in terms of women's health. There's a wonderful book which is called The Knowledge by Dr. Nagat.
I didn't pay him to do that.
Which talks about women's health, essentially from menarche, so the started periods all the way through to menopause and beyond. And I think it's really important that boys and girls, men and women, are all educated and informed about this, because we need to remove the stigma, taboo, shame around things like periods, miscarriages, terminations, menopause. I find it really heartbreaking. I'm now at the age where my friends are getting pregnant, and people that are close friends, they don't really tell anyone that they're pregnant until they've had their 12-week scan. And it's really sad because it means that they're essentially they've reduced their support network around them while they're going through all of the horrible symptoms of the first trimester. And then if they miscarry, all of that trauma and just horrible mental trauma, the physical trauma associated with it is just, they just have to try and deal with it by themselves, which I just think is really sad. It's heartbreaking. Another thing that I thought was a good takeaway point today was about empowering women better during their birthing journeys and during labour. So explaining better the different options that are available to them, the potential outcomes, the risks, the benefits, and allowing the lady who's about to give birth to be more active within the decision-making process when it comes to the things associated with their pregnancy.
Some of the things that I thought was fascinating as well was the role of primary care and general GPs. So one of the things that Victoria Atkins discussed about was making sure that from birth or even before pregnancy, through pregnancy and after pregnancy, that a woman has consistent advice and healthcare, particularly because she touched upon the harrowing figures that we see in Black and Asian communities. So Black women are 3 times more likely to have a birth complication or even die from birth complications, and South Asian women are more likely to be 1.7% chance, and that is an issue that needs to be tackled as well. I think as clinicians we were discussing how the proposed idea that GPs within 8 weeks need to have a maternity care, whether that is at the moment something that's feasible or doable, and how the government will deliver on that would be fascinating. What are your thoughts?
I mean, people are already struggling to get appointments with their GPs. We don't have enough GPs, there's not enough funding. The public, whilst there was this massive push to improve access to someone within a primary care or a GP team, we're not really, people still want to see a doctor rather than a physician associate or an advanced nurse practitioner or a paramedic, and they can be excellent and they have very specific roles within the primary care team, but they won't be able to take away this additional demand from doctors, because I suspect it will only be GPs who will be able to carry out these reviews. And even if something's wrong with the stitches or the suturing after a tear, if there's not a full recovery, I don't think the GP is best placed to then manage the onward care. That has to go back towards the hospital. So why are the hospitals not doing the 2 weeks?
Currently, I think that's the deficit that we have, postnatal care for women afterwards, whether it's, say, birth trauma, which was touched upon today quite extensively. We didn't even discuss, actually, one of the things that I was thinking we would talk about was mental maternal health afterwards. So before pregnancy, mental maternal health, and then things like postpartum psychosis or postnatal depression or even baby blues, because I know that we're struggling with that in general practice. That was also an area that was touched in year 2 in the Women's Health Strategy. So before anybody leaves a comment and says it is part of the strategy, I know it is, but today there didn't seem to be any further progression on what was discussed a year ago. One of the things that in the Women's Health Strategy discussions that we had today with the Health Secretary, there was a real investment in FemTech, which for me was, I know it's something that you and I are immersed in a lot, because we come across some FemTech a lot on social media and as content creators. But it was really lovely to see quite a lot of FemTech companies come to the summit.
Yeah, I thought it was brilliant. One that I think one of the ones that stood out for me, mainly because it's one that, so I've worked quite a lot in orthopedics in the past, and there's a way to look for osteoporosis from x-raying the wrist, and I thought that was amazing. They look at a couple of different points, and they look at the bone density from an x-ray, and they say they get a 1-to-1 correlation with DEXA scans, which is the gold standard. But you'll probably appreciate this as much as I do. In practice, sometimes we're waiting 3 months for a DEXA scan for a report.
Oh, you're like, I was going to say, to get a DEXA scan in my area, I think it's like a year or maybe even 2 years for a DEXA scan in some areas. So
that's
there's
brutal.
a real postcode lottery. But also, yeah, absolutely right. It takes about 2 or 3 months or so to get a report. So the FemTech today at the Women's Health Summit was really, really fascinating. The other thing that was really fascinating was the focus on research. So to tackle a lot of the gender bias research that's happened. And we did have Lucy, who's a lead for research advisor for the government, who was there today, and she did say that one of the key areas that they're focusing on is maternity health, menstrual health, and also menopause and postmenopause. So we know that hormone replacement therapy for breast cancer patients is not advisable at the moment. Systemic hormone replacement therapy for breast cancer patients is not advisable. So this is fascinating that there's a real focus for the government to look at really the ways that women need to be researched better in regards to different stages of their life, not just a particular stage, which for me, I feel all of them are under research. It was amazing to have Emma Cox from Endometriosis UK, again talking about menstrual health problems and the lack of research with endometriosis. So that was fascinating at the Women's Health Summit. One of the things that I thought, Sooj, was really interesting was looking at disparities and inequalities, because you and I have discussed this a lot before. And you being a content creator, you get a lot of, when you do make women's health content, do you get lots of people from different backgrounds contacting you for advice?
Yeah, I do. I get loads of comments. Again, people ask quite personal questions, which I can't really respond to because we're just not
We
indemnified
can't
for
give
that work.
personalised medical advice, guys, on socials. Really sorry, but
So
that's
what-
because it's clinically unsafe, not because we're being mean.
But what I do try to do is, if it's something that I think could be applicable to a lot of people, I will then make a video about something, but with like the generic explanation behind it, because I guess people don't know what the correct sources are to try and find information themselves.
Yeah.
To just try and improve access to that credible health information. What were your thoughts on that?
I thought it was fascinating to, again, go back to the fact that we're saying that marginalised communities need to be part of the solution, because we always come forward with problems, but actually what are marginalised communities doing? So I got the opportunity to show you our Health Collective report today, which we brought along from Wellbeing of Women to the summit. The Health Collective is essentially in twofold. The steps are going to be taking place. It's actually not my thing, it's the collective thing, so I'm not taking any credit for this, and Dame Leslie Regan and I are just facilitating this. It was an idea that came about because we realised that there's a lot of mistrust of mainstream healthcare. Also, marginalised communities know how to communicate within their community in order to deliver women's healthcare. But we wanted to map them so we know that this work is happening. So, for example, up in Newcastle, there's Apnagar. In Birmingham, there's Sisters, which looks at marginalised groups in endometriosis care, and they've actually got a conference that's coming up. And then we've got 5 times more, which is tackling inequalities in regards to maternal health outcomes for the Black community. I could name so many, but we've mapped 68. The idea of mapping these groups is that when it comes to writing the clinical pathways for the Women's Health Strategy, which is the whole reason why the Women's Health Summit happened today, then we've actually got this resource of groups who already have the trust and also are able to guide us in writing the clinical pathways and allows research and care to happen. So if anybody's watching this and they think they want to get involved, then please do have a look at the Wellbeing of Women's website, and there'll be so much more information. I might make up a follow-up video to explain that a bit more clearly than I have done today. I hope that made sense.
No, it did make sense. Just one thing about the gender inequality. Women are not little men.
Yes.
And one of the things that I found very surprising, so there's a book by like Caroline Criado Perez, where like she talks about the way that society has just been built around men, and like even crash test dummies in cars was based on an average sized man, not even someone with breasts or someone that was smaller or had a different weight distribution. It just blows my mind. It
is, and do you know what? The other fascinating thing that I realised recently was the fact that it was only 1993 when it was decided that women need their own arm of research. Like 1993, guys, that's when they thought women now need to have their own sort of area of research and looking at. And it's only in this year, on the 3rd of January, in Hormone and Behaviour magazine, was the first bit of research that came back, which was actually started in 2018 and before that, that concluded that actually estrogen is linked with ADHD behaviours. So get this is absolutely fascinating. So neurodiverse communities are the most underserved. I mean, we know we have lots of underserved communities, LGBTQ+, Black communities, Asian communities, but neurodiverse communities. And one area of research, which I've done a podcast on recently, it's on my Instagram page, but what's fascinating is that lowering of estrogen actually means that ADHD behaviours increase, so such as high executive functioning, higher levels of inattention, high levels of brain fog, inability to stay focused on tasks, affecting your sleep as well. The fact that you're fidgeting a lot more, you might have spells of hyperactivity. So we know that there is a gender disparity in ADHD being diagnosed. Men get it diagnosed more than women do because women mask a lot of the hyperactivity symptoms. And now we've realised actually it's very intrinsically linked with their menstrual cycle. So this is incredible amount of research that's come out, available in Behaviour and Hormone magazine. And this is something that we're going to build on because I see this in my clinics. as a women's health GP, that when I get to perimenopause and you pull apart a lot of the symptoms, as the estrogen is declining, their ADHD behaviours are getting worse. And I think this is so fascinating. We now have like scientific evidence to say that your estrogen levels are intrinsically linked with the neurons in your brain, and we can't just fob women off and go, oh, it's just your hormones or too much of your hormones. In fact, it's not like that at all. Too little of your estrogen directly impacts on your brain. And if we even sort of stretch that even further, then we could be looking at premenstrual syndrome symptoms, PMDD, even postnatal depression when a woman gets a decline in estrogen as well. So from my point of view today, I thought that if they are looking at tackling health inequalities, then one of the things that we should really be looking at is pooling all this data together, which I'm hoping that the Health Collective will be, because the Health Collective isn't just for Black and Asian communities, it is for all marginalised communities. So that's a rundown of a lot of the things that we sort of could remember from today. It's very much the same stuff, I have to say, from the last 2 years. This is the 3rd year of the Women's Health Strategy, but the first year that you joined us.
I've been here, yeah, so that's nice.
So I went to year 1 and year 2, and now I'm here at year 3. And I suppose now it's about deliverables. I am tired of hearing the same things. And so I'm hoping to continue work on the Women's Health Strategy to provide deliverables. And I hope that you continue to make content with me.
Absolutely. Yeah.
And I didn't force him to say absolutely. Thank you so much for joining us on this impromptu video. If there's any comments, please leave below, like and subscribe. We'll put both of our handles in there as well. And we might make this a regular thing if this works out.
I think it'd be really good.
We might have to see. All right, bye.